Pune. And this session is sponsored by Sanofi, so thanks Sanofi. We're going to talk something very basic, very simple. You're not going to learn like the new cutting-edge MPA kidney or some musculoskeletal disorders, etc. What you're going to listen to is something which is mundane, which is basic, and which most of us in this room, including me, is guilty. That is not starting insulin early. And the only take-home point for the next 20 minutes is, please start insulin early. If you get this take-home message, you can go and have a cup of coffee after this. 52-year-old man, diabetic for 18 years, the usual hypertension, hyperlipidemia, hypothyroidism being treated, no significant past medical history, no tobacco use, surprise, surprise, occasional alcohol consumption. BMI, he's obese, Indian standards, blood pressure is controlled, mild NPDR, fasting 196, PP 287, HbA1c 8.9, CKD stage 2, A2 albuminuria. It's got some neuropathy, triglycerides 184, thyroid is normal, uric acid normal, probably has MASH, but SGPT is 32. He's on gliclazide, which is very odd, I think, in India. Most of us use glimepiride. My humble request, someday we can have a debate, probably switch to gliclazide. Sitagliptin, metformin, unable to afford a GLP-1 RA, which is a very common thing in our country. DAPA 10 milligrams. So he's on an SGLT2 inhibitor, which Avdev was telling you. Please start an SGLT2 in every patient unless and until there's a contraindication in 2023. On telmisartan and amlodipine, on atorvastatin, and on thyroxine 75. So how will you manage his glycemic status? Second line. Please get interactive. Raise your hands. Nobody's seeing you, so raise your hands. How many will add pioglitazone? One person. Thank you, sir. How many will add pio plus voglibose? Come on, in India we do that. We go for 6, 7 drugs. Nobody? Okay. Add basal bolus, stop gliclazide. 1, 2, 3, 4, 5, 6, 7. Oh, baap re baap, sab ke sab. Change gliclazide to glimepiride, which most of us do, and DAPA to MPA. You just had MPA kidney. No takers for point number 4. Add just a basal insulin, continue all. Come on. Yeah, great. Add pre-mixed insulin, co-formulation insulin. Come on, guys, be honest. Be honest. Only 3 hands went up for pre-mixed insulin. Okay, sir, thank you, 4 hands. Then my talk is done. Sanofi, can I go? Introduction. By the time diagnosed diabetes is made, patient has lost probably 80% of her beta cell function, not 50%, which UKPDS showed. This is a very nice data done very nicely. So most people with type 2 diabetes, if they live long enough, will need insulin. But look at this. This is a landmark trial which is being quoted left, right, and center. This was an observational study where about 6,000 people in India have been seen at baseline and at 3 years. What they found was there's no additional benefit if you add the 4th OHA. Come on, how many of us in this room use 4 OHAs in a patient? How many use 5? Okay, thank you, you're honest. Less than 1 in 4 in India get insulin, and average HbA1c in our population is 9.2. So that's take-home message, please start insulin early. And that's the number of insulin preparations you have in India. We are fortunate to have everything that you want. Only remember, Icodec is not even approved by FDA. So Icodec has got 4 asterisk marks. So there are, from below up, if you see this faster-acting aspart, faster-acting Lispro, you have glulicin Lispro, you have regular, then you have the premixes, IDEC as premix, and then you have a whole lot of basal. See the number of basals available, which tells you what? Start with basal. When you start with basal, starting is simple, low incidence of hypoglycemia, lower chance of weight gain. What's the cons with it? The effect on PPG is not that great, lesser control of HbA1c, and requires adding additional different types of insulin for intensification. And most of you did not raise your hand for premixed insulin. I'm very surprised. Maybe Pune has advanced, because the commonest insulin used in India so far is premixed insulin. Why? Again, because a simple start, effective HbA1c control, controls both fasting and postprandial glucose, and option to intensify with the same insulin. How many of you use premix 3 times a day? Yes, sir, thank you. What are the cons? More chance of daytime hypo, more weight gain. Now, these are the advantages of a basal insulin over premix or IDEC-ASP, which is exactly what I said. It's just to tell you that there's some data. I'm not just listing those lines out of my hat. Versus premixed insulin, overall and nocturnal hypo is less. I mean, it's not a rocket science. It's less because premix has got a rapid-acting insulin. Same with BIASP 30 and same with IDEC-ASP. So lesser hypoglycemia if you start with basal insulin. Coming to weight gain, we all know that when you start insulin, be upfront, tell the patient anywhere between 2 to 4 kilograms weight gain will happen if they're on insulin for 1 to 2 years. With basal insulin, there's a lesser weight gain, 35% less as opposed to BIASP 30 and about 35% less as opposed to IDAC-ASP. But whenever you read, there are hundreds of trials comparing basal with premix, basal with IDAC-ASP. Whenever you read these trials, you will get an answer either way. So whenever you read these trials, be very careful about these 3 points. Units of insulin used, what was the weight gain, and what was the hypoglycemia rate. Because in some trials, they've used lesser amount of basal. Of course, you will have less hypoglycemia, less weight gain. In some trials, they've used lesser amount of premix when they're comparing with basal. So always try to see if this has been matched before you interpret the trials. So if you want to start insulin, basal plus, basal 2, basal bolus, or premix co-formulation once daily, twice daily, thrice daily. Any one is right. I'm not trying to tell you that you choose the left panel or the right panel. My only humble request is please choose any one of them and start insulin early. Now this is what's the current use of premix versus basal insulin in India. This is 2011, about 13 odd years ago, the DiabCare study. If you see half the people on insulin in India in 2011 were on premixed insulin and about 12 to 13% were on a basal insulin. Fast forward 2017, it says a large Indian cohort, wasn't that large, 750 odd respondents. Whichever combination you see, and there are some funny combinations, premix plus basal plus Plantrial, anyway. But if you see, almost 80% of the people are on premixed insulin and 20% on basal. This is 2017. Fast forward to 2024, the famous landmark trial which we quote. Now look at the left side. At baseline, there were about 6,000 patients, of which about 5,000 odd, if it's in top left panel, 5,000 odd were followed up completely. At baseline, 13.5% were on basal insulin. Look at the right side of the panel, 11% were on the premix insulin. So India is changing. And that's what I saw just now. When I asked the question, majority of you raised your hand for basal insulin rather than premixed insulin. And by 3 years, control is deteriorating. People are getting added on the insulin. And if you see basal insulin goes up to 22.8% as opposed to premixed insulin. So are we changing? I don't know. This is a small cohort. It's not a representative of the whole country. Patients have been studied from different states, but there are only 6,000 odd patients. So what do you do? Now, what were the reasons for earlier underutilization of basal insulin in India? And this is the first and foremost one. We are told that we eat carbohydrates more. And this was based on this famous study called the START study. What is the glaring problem with this START study? If you look in the north, look at west, look at central, look at south, look at east, everybody, 2/3 of them are having carbohydrates. Impossible. Can't happen. And that's why this study had limitations. And what were the limitations? It was a cross-sectional design. It was a very small sample size. You study about 800 people and you say this is Indian data. Come on. Measurement error of diet. Single visit. First, one visit, the patient comes to a specialty endocrinology or diabetology clinic in 10 centers. You ask them, what are you eating? I eat rice 3 times a day. There you go. 60% of the time, you're having carbohydrate. So this is not a very representative data of all the population in India. You just ask yourself, are you having 60% of the times carbohydrate? I think no. India has moved on. The other reason it said is, unlike Caucasians, both fasting and PP contribute equally to HbA1c quantiles. That's correct. This is the famous Monier data way back in 2003, 20 years ago. This slide you will see 100 times. I'm showing you the 101st time. If you see, as the HbA1c is high, contribution of basal is higher. Fasting glucose is much higher on the right-hand side. As the HbA1c goes down, the contribution of PP goes up. And then this is this trial which is touted as the Asian trial. This trial has only been done in Taiwan. There is no Indian data. Nobody has done this kind of study in India or in any other part of Asia. The Taiwanese trial, where they have shown that no matter whatever is the HbA1c, the contribution of basal or PP to your HbA1c is 50-50. So 50% of the contribution to your HbA1c is still elevated fasting sugar. Fix that. Get the fasting down with a simple basal insulin. The third reason people don't want to use basal is basal does not target PP glucose. It does. If you bring fasting is here, PP is here, you bring fasting down, automatically PP comes down by itself. Plus, there is a study, I can't take you through this study in such a short time, Just read the boxes that if the young individuals with diabetes, lower baseline HbA1c, higher markers of insulin secretion, and they have lower OGTT at 2 hours, in these people, if you're using basal insulin, not only do you get your fasting under control, but you also get the PP blood sugar under control as well, not as much as you would with a prandial insulin, but it does bring your PP down. What was the fourth reason of not using premixed insulin? When I grew up, we had split mix. We did not even have premix. We had a syringe where we had to add basal, we had to add rapid acting. Then came premixes in India. And that is the reason why many of us in this room have been using premix. We were brought up on premix. If a child starts learning Bengali, he will speak Bengali when he grows up. He will not start speaking Marathi. I can't speak Marathi, sorry. So it is late initiation of insulin. And this is not Indian data, this is UK data. Kamlesh Kunti, I think, is here in this meeting somewhere. I think he's speaking in the other room, I think. What he tells you is, we start at 9.2. Look at the British people. They start at HbA1c 9.8. Americans are equally bad. And the median time to start insulin is 7.7 years. You think of starting insulin today, by the time you write that insulin, you or any of us, when we see the patient, the delay is about 7.7 years. Shame on us. Before initiation of insulin, HbA1c more than 9%, this is US data, UK data, is about 1 year. HbA1c more than 7%, 4 years. So why do we keep talking about what is the target HbA1c, blah, 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 blah? We don't want to reach the target HbA1c, we don't want to start insulin. 2-3 drugs failing, please start insulin. The reason we use premix is because we start insulin so late. HbA1c is 9.2, 10%, where fasting is 300, PP is 600. Basal probably is not going to work here. Fifth reason why people thought about using premix is inability of basal insulin to maintain HbA1c for long. Again, this is wrong. If you start basal insulin early, this is the origin trial. I'm not saying in origin trial everybody had diabetes. Quite a big chunk of them had pre-diabetes, but there were 22% people in origin trial who had diabetes. HbA1c was more than 6.5. And this was a 7-year trial. And if you see, this is fasting glucose data, that's what they presented. In the origin trial, just by using glargine, they could maintain the glycemia for a period of 7 years. You start when the HbA1c is 11.2, of course basal insulin is going to fail in 6 months. What we are told in India is basal insulin fails in 6 to 24 months. Of course it will fail, because you're starting it after 5 OHAs, after 15, 18 years of diabetes. Start insulin early. There's lack of appreciation about the cardiovascular outcome trials done with basal insulin. Insulin is the only molecule which does not have cardiovascular outcome trials. We talk about so much about cardiovascular CVOT. We want to kill sulfonylurea, other drugs, acarbose has. Because they don't have a CVOT. None of your insulin preparations have a CVOT trial, except the 2 basals. The origin trial, this was the cardiovascular outcome trial, way back in 2012, and the other one was with Degdudec, the DEVOTE trial. So if you want evidence-based use of insulin, basal insulin has got the evidence with regards to cardiovascular outcome. It does not, it's safe, does not protect. Of course it will protect if you get the HbA1c down. The biggest protector of cardiovascular disease is if you can get your HbA1c down. Again, that's a debate we can talk later. 7th reason why we kept using premix is what I just told you, familiarity. We grew up with split mix. Then we grew up with premix. So it's easier for us to use premix in India. Whereas if you go to the Western world, they grew up with basal. So that's why they are using basal. That's the guidelines push. If you see all the Western guidelines, it's slightly dated, 2019, but you can add 2023 up here. All of them start with basal insulin. And what happened in India? There were 2 guidelines, there's 2012, and there was another one in 2015. They kept telling us start with premixed insulin. And that's why we kept using premixed insulin. But things are changing, as was seen when I asked the question here. Most of you raised your hand for basal insulin, and that's what's happening now. 2019, Dr. Bajaj came up with this expert opinion, which said be smart. Be smart means basal early, along with continuing your OHAs. And then now if you see the latest RSSDI ESI guideline, I don't think you can read it. I don't know if you, can you? It says initiate now with once basal, once premixed, or twice daily premix, and that will depend on the patient's age, clinical features, glucose profile. That's why I said you can use basal, you can use premix, but it depends on when you're starting, how you're starting. So I will leave enough time for questions, because I want more questions than a lecture. Because this is something which is practice, and you have to share your experience. So coming back to my patient, 52-year-old, 18 years, He's already on a SGLT2 inhibitor. HbA1c is 8.9, fasting 196, PP 287. Now raise your hands again. How many of you will add a premixed insulin? Fasting 196, PP 287, HbA1c 8.9. 18 years of diabetes. Premixed insulin, co-formulation, and basal insulin. Yes, sir, that's my take. It's not because it's a Sanofi-sponsored session, because if you go back and see, some of the things which you see is, what is the difference between fasting and PP? So fasting is 196, PP is 287. So those numbers are given pointedly, you see. So if I can get my 196 down to, say, 90 or 100, my PP is going to come down, and I can start easily. Starting basal is easy. One pen at night time, you don't have to carry the pen, it's not before meals, etc. Then if you fail, you fail, and you can go up, you can intensify. So reasons for paradigm shift, which has happened here, thank you. Fixed fasting first, better efficacy and safety data over premixed co-formulations, lesser hypoglycemia, and holistic glycemic control. Now comes the other question. So all of you have decided basal insulin. Now which basal insulin? You have NPH. How many of you use NPH as a basal insulin? In all people, sir, or only in pregnant ladies? Pregnant lady, I'll raise my hand. Otherwise, also? We'll have a discussion later on, sir. First generation, which is Detamir Glargine U100. And how many of you use the second generation basals, Glargine 300 and Degludec? Yeah, we are India. So many hands went up for second generation basal. Okay. We can have that in question answer session. So Glargine U100 has been studied for a long period of time. It's efficacious, safe, convenient. Cost is an issue if you choose between Glargine 100 versus Glargine 300 or Degludec. Insulin initiation is very simple, 1, 2, 3, 1 prick a day, 0.2 units per kilogram, but that is not sacrosanct, depending on the patient's BMI, depending on whether there's ongoing sepsis, patient on steroids, and titrate every third day. Patient has to titrate by doing the CBGs. Now, my talk was just initiation, but always remember, just initiation is not good enough. There are a lot of studies which have shown that people start insulin, they forget to titrate and intensify. So please titrate. Every third day, patient should do his or her CBG, titrate to a fasting between 100 to 130. Take your pick. Each guideline tells you different. I tell my patients 100 to 130, keep increasing by 2 units. And once basal fails, please intensify. And you can intensify by basal plus, 1 plus, whichever is the higher postprandial. Or if you want, you are welcome to switch from basal to basal bolus, or you can switch from basal to premix. So initiate, titrate, and then intensify. The biggest question in India is cost. So many of you raised your hands for second generation basal. The advantage with second generation basal is slight reduction in nocturnal hypoglycemia and maybe a very minimal advantage with regards to HbA1c control. The trial between GLA 300 and GLA 100, the added benefit was about 0.4% in HbA1c, but cost difference is there. So if your patient can afford, certainly go for second generation basals. They are an advancement over first generation, but first generation basals are good enough. And prior to this, we are a biosimilar market. We have a lot of biosimilars in India. You can read the names at the bottom. But now, the innovator Glargine and the biosimilar Glargine, the price has become same after Government of India's intervention last year. So key takeaways, basal insulin is recommended as the most convenient insulin regimen. Everybody agrees? Glargine 100 has emerged over the course of time as the gold standard. Anybody denies it's a silver standard? Everybody agrees the gold standard? Okay. GLA 100 plus OADs with adequate titration can help people with type 2 diabetes achieve sustained control for more than 2.5 years. There's data for that. And basal plus approach offers better flexibility and low hypoglycemia risk versus premix and insulin. So with that, I'll stop. Thank you very much for patient hearing.
Thank you, Dr. Mukherjee, for taking us through the rapid journey of insulin, right from the initiation, taking us through various trials, landmark, and origin about insulin. I think we can take both questions together.
Whatever you say, sir.
Okay. So, what are the questions? The house is open for the questions.